Kia ora koutou, and welcome to tonight's Goodfellow webinar, brought to you by Te Whatu Ora as part of their series Te Tiri Whakaaro Sharing Knowledge. My name is Pulasti. I'm a GP based in Central Auckland, and I will be your facilitator for tonight. To summarise what we'll be covering tonight in our webinar, so we'll be talking about diabetes and pregnancy with Dr. Lakhdhir providing an overview of pre-existing diabetes and how to optimise pre- and early pregnancy care, and GDM in the setting of pre-diabetes and previous GDM. Following this, we will be having our standing segment on clinical updates with Dr. Tutty. Firstly, a bit more about our speakers. So Dr. Heena Lakhdhir is an obstetrician and gynaecologist with a special interest in high-risk obstetrics, including preterm birth and diabetes in pregnancy. She works at Te Whatu Ora, Counties Manukau. And Dr. Tutty is a GP and primary care advisor for Te Whatu Ora, Counties Manukau. So, without further ado, I'll pass you over to Dr. Lakhdhir.
Hello, everyone, and thank you so much for being here. And thank you for the kind introduction. So I'm an obstetrician at Counties, and I'll start off by a little bit of a background where I come from. I'm originally from India. I've been in New Zealand for about 14 years, and I have a 21-year-old daughter. Here in South Auckland, as most of you are aware, we have a diverse population. A lot of our women have quite difficult and challenging lives, struggling work, life, children, sport, church. And in today's times, there is food insecurity and quite a bit of struggle. Our baseline rates of type 2 diabetes are also higher than some of the other parts of the country. In myself, I have always been a bigger person, so I kind of am really passionate about the HAZE approach and a sort of respectful approach to weight and size. So having said that, we'll jump into the talk. Now, as many of you are aware, there are differences in the country on how we do things in the sphere of gestational diabetes. We are in the process of writing the national guideline. And in the national guideline, what we aim to do is to bring together all the areas of the country and try and come up with a framework. That, of course, is in draft form, and we haven't got there yet. So I will talk a little bit about what is happening at the moment, what happens around the country, and what we hope will happen. First, I'd like to start with the really simple part of it, which is pre-existing diabetes. When we think about pre-existing diabetes, this is someone who's had an HbA1c of more than 50 in the past, or we think they have it on their booking bloods. If you've seen it on their booking bloods, another term used sometimes is overt diabetes. In times to come, we hope that this will become an HbA1c of 48, as that is what it is in a lot of places in the world. But if there is somebody with pre-existing diabetes or overt diabetes, their risks are different, and we'll start with that. So if you have somebody with pre-existing diabetes, whether it be type 2, type 1, or other less common forms of diabetes, we'll start off with what we ought to do in the preconception period. Of course, we know that less than 50% of pregnancies are planned, and we very often aren't able to get into that preconception phase. Some of these things we could try and attempt to do in sort of the first visit. Now, I know all of you are very, very busy clinicians, and I know in the world of primary care, everyone is super pressed for time, and a lot of this is not possible in that little time that you have, but this is where we are at the moment. So when we see someone in the preconception period, this is something really interesting that I came about. Most people don't plan their pregnancy, but a question could be, would you like to be pregnant in the next year? If you fall pregnant in the next year, would you be happy? And if the answer is yes, then that's planning a pregnancy. At that time, depending on how they are in their journey or where they are in their journey of type 1 or type 2, we'd like to have a small discussion around the risks of miscarriage in the first trimester, congenital malformations, preterm birth, and preeclampsia. And as we go on through this, we will talk a lot more about these. A discussion around nutrition, eating, diet, lifestyle, moving as best as they can, whatever is appropriate for that person. Starting on folic acid 5 milligrams in the preconceptional period is extremely helpful. The issues that you then want to screen for, again, all of you as clinicians are well aware, you want to do a blood pressure, record it, and start medication. Screen for coronary artery disease. We are seeing more ischemic heart disease in younger women, and especially if they've had type 2 diabetes. So this is something to think about. Their retinal screening, diabetes, kidney disease, a creatinine, and a urine PCR would be great. Any signs of autonomic neuropathy? Again, we've had women with gastroparesis, and if we've known about this earlier, that would be fantastic. Diabetes, foot disease, thyroid, celiac disease, and mental health. We know about diabetes distress, denial, depression, and many other conditions that come with this chronic disease burden. We now do have a psychologist in our diabetes and pregnancy clinic, and if you are to find that the young person or the young woman does have challenges, then it will be great to hear about them on their referral. And dental health. So this is just a picture I've got here to show how that very early management of blood sugar and of their diabetes is vital. As you can see, once you've gotten to those first few weeks where they're still with their primary care, you've already got the CNS, the neurological system being formed, the heart, the upper limbs, and the commonest abnormalities associated with pre-existing diabetes are neural tube defects and cardiac defects. So early, there is a sense of urgency in enabling the young woman to manage her blood sugars better in that early, very early period. Often, of course, these are only diagnosed at the anatomy scan or at a later time, a nuchal scan. This is, I don't want to be alarming you, but this is just to show what the risks of anomalies are in association with pre-existing diabetes. And this is not uncommon in the women we see. So as you go with worsening diabetes, and I've just put the numbers here, so 11.5 is 105, you almost have a 30% rate of major anomalies and a 40% rate of minor anomalies. This sounds really high, but it's quite disheartening. I'm here on Tuesday in Diabetes Clinic, and this week we saw multiple neural tube defects. Last week we had another lady with a cardiac defect. So it is something we're seeing, unfortunately. And this is where the role of early management or possibly preconception management would be fantastic. This is a slide that I've got. I was at a conference for ADIPS in Perth and returned just yesterday. So I have picked up some slides from there, and I apologize for how they look. But there were some really interesting things discussed there that I brought here. And so this one just shows what the rates of, congenital anomalies, but also perinatal deaths is in women with increasing HbA1c levels. And an HbA1c that is lower is associated with less preterm LGA and NICU admissions. So as we've said, with pre-existing diabetes, it's not uncommon in areas of South Auckland for the person to present for the first time when they're pregnant, providing a blood glucose monitor, testing scripts, testing instructions. There are videos on the Auckland Hospital website as well as on Counties Manukau websites. CareSense itself has videos, so it would be great for people to start testing their blood sugars. Medication, I'm going to keep it really simple. Metformin and insulin are safe, So absolutely fine for them to continue or start on metformin and to go on to insulin. The new inhibitors and newer drugs, also I heard at the conference that there are studies now, early studies where about 1,000 women who happened to be taking them in the early trimester did not have any congenital defects. So the thought process is it's safe to give them in that childbearing age rather than stopping them, because more and more women seem to fall pregnant as they get on the newer medication. So we can reassure women who are on them prior to pregnancy that there has been no harm seen thus far. Of course, once we know they're pregnant, we're going to stop them and switch them over to metformin or insulin. Again, antihypertensive medication, labetalol, methyl-dopa, nifedipine are all safe and can be started off to replace their ACE inhibitors and ARBs. Aspirin, 100 milligrams, still okay. We want to be giving this ideally between sort of 12 and 16 weeks because this will improve placental vascularity and reduce the risk of small for gestational age in especially women who have known vasculopathy or long-standing diabetes. We know that in Maori and Pacifica women, this seems to be about 5 years, and in Caucasian women, about 10 years. So ideal to start aspirin. Calcium and supplementation, we say if they have a low calcium diet. Vitamin D, it's just a plug for vitamin D there. As we've said, folic acid, iodine. It would be great to have an up-to-date weight and BMI measurement just for dosing and to kind of see what the gestational weight gain is. And then, of course, you would do your usual obstetric care, which is get the person to find themselves a midwife or refer to community midwifery, refer to secondary services, get them a form for a dating scan. If they did want an MSS1, then provide them with the information for it. And I appreciate that that's all quite hard to do in one appointment. Unfortunately, in counties, dating scans need to be paid for by the person, and that really restricts some people from getting to them. So that is a barrier to care right at the start. Now I'm going to come to the other part of gestation. So we've done the pre-diabetes, we've done women who had a booking HbA1c, have a hemoglobin of 48 or 50 and above. We're now going to talk a little bit about early GDM. There is a study called Toboggan, all right? And this has been done in Australia by David Simmons in the last 7 years. And we now have good evidence that early treatment of gestational diabetes is better in terms of managing and for adverse neonatal outcomes. The main outcomes that were seen to be better were respiratory outcomes. As you can see in this graph here, the women who were in the higher glycemic range, and I'll explain that in a bit, and who were seen before 14 weeks seem to have the most benefit. Similarly, with pregnancy hypertension, those women seen before 14 weeks. So how does that translate to us? This is where various different DHBs and areas do things slightly differently. For instance, in Auckland area, Auckland Hospital and Waitemata, I think, will see women who have a HbA1c at the start of pregnancy between 41 and 49 and start testing their blood sugars. And they enter the diabetes clinic as if they had early GDM and continue to get management after that. In counties Manukau, we will ask people to have a GTT done at 24 weeks to 28 weeks, and that is how they enter our service. To explain that a little bit more in terms of the HbA1c, I've put 42 to 47. We are hopeful that in the national guideline, we will be able to sort of bring the country around together to use 42 to 47 as the pre-diabetes or early GDM, and that these women would come through the clinic. We have good observational studies from New Zealand by Ruth Hughes and Janet Rowan and others. We now have multiple studies that show that these women are at greater risk in pregnancy, and identifying and managing them has multiple benefits in terms of perinatal mortality. So going back, in the Waikato region, I think an early GTT is done. So there are differences in the country as to how we manage early GDM. Australia might move to a GTT at 14 to 16 weeks. So for this bit of early GDM, for the moment, you'll still have to follow your local management, but understanding that women in that pre-diabetic range continue to be at increased risk. With the GDM, we would like to propose that it's done at 24 weeks rather than the 24 to 28 weeks, because by the time the woman gets the form, does it at 28 weeks, gets referred to clinic, it sometimes is about 32, 33 weeks by the time she's seen, and that seems to be quite late to make a tangible difference. And so we would like women to be given a form for GTT once they've had their anatomy scan and be told, this is what we want you to do at 24 weeks. Currently, we have a two-step format, which is women do a polyglucose or a challenge, a glucose challenge test. If that is positive, they go on to do a GTT. We would hope in future to come up with a one-step test only, which is the GTT, and make that a simple test with a fasting in a 1 hour. But of course, this is only proposed at the moment. We're not there yet. The current GTT cutoffs, don't want to add a lot of confusion here, but we are at 5.5 fasting in 9 2 hours. The international guidelines in Australia are at 5.1 and 8.5. We hope to get to 5.3. Now, I'll just explain that if you look at this diagram, this is the big HARPO study on which all of this is based. This was a large multicentric study that showed for the first time how outcomes relate to blood sugars. And with the level of hyperglycemia, it is a continuum, and that is the most important thing. The cutoffs vary, but it is an ongoing continuum. And these numbers are the 1.5 standard deviation or 2 standard deviations from normal. So once you're getting to 5 or 5.1 or 5.3 or 5.5, these are abnormal blood sugars. So I hope I haven't confused anyone at the moment, but currently we diagnose GDM based on a GTT at 24 to 28 weeks, and the cutoffs are 5.5 and 9. I've just put this graph to give sort of an idea of why we choose that 24 to 28, because insulin resistance increases at that time in pregnancy. And by doing the test when insulin resistance is rising, we hope to pick up the most number of women that are experiencing insulin resistance and are possibly being diagnosed as gestational diabetes. If it is negative here and you do find that the women continue to have risk factors, the GTT can be repeated at 30, 32 weeks, usually not after 36 weeks because we don't have enough studies on how to interpret it. This is risk factors for GDM. Now, in New Zealand, we're doing universal screening. So we aren't really, looking at risk factors, because we know that by risk factor screening, we will leave quite a few women behind. But a previous GDM, a previous large baby, an elevated BMI, someone who has other chronic metabolic conditions, anyone on steroids or antipsychotic medication for long, a good strong family history of diabetes, a previous loss or preterm birth, especially a term stillbirth. These are women that are at higher risk. And of course, previous GDM, we've said that. We would really encourage these women not to go for not to sort of do the 2 steps, not the glucose challenge and then the GTT, but just the GTT straight off, because it's very likely that these women will need treatment and management of that. So what would we do as part of their antenatal management? Of course, continue the blood sugar management. For blood sugar monitoring, the women will start off with seeing a dietitian. Again, this is not homogeneous in the country. Some areas are unable to offer dietary support. Some areas, such as Christchurch, have this really fantastic service where the dietitians triage, see women, chat with them, and ensure the women are able to sort of modify their diet before they go on to medication. And in our setup, we've got to be really mindful of the food insecurity that people may have, be accessing food banks. So really tailor it, individualize it, and that's what we hear from women. There is no one size fits all. Cultural differences exist as well. Once the woman has attempted to do that, or is able or unable, we'll see how we go. The next steps will be to get onto medication. Medication is in the form usually of metformin in New Zealand in most areas. We have studies from the large MIG study group. We now have the MIG outcomes and metabolic and body composition. It is essentially safe medication. There is some increased rates of obesity in young children, but again, we don't know whether it is the diabetes or the metformin itself. And given this reassuring data and that metformin is well tolerated by most women, and most women would like to try medication before insulin, metformin is offered. It does cross the placenta. Insulin, on the other hand, is extremely safe and does not cross the placenta, so some women may choose to go on to insulin straight away. I've just put a little plug here. When the women are referred from primary care to secondary care, it would be wonderful to know about the woman's work, their lives, their working hours. We have women who work night shifts, who are on a forklift, who are teachers, and it would be great to sort of know where they are in terms of how they're able to manage. Testing and treatment can be individualized to a large extent to what is needed for that particular person. So that's sort of their blood sugar management. We'll in through the antenatal clinics, growth is monitored to look for both large for gestational, small for gestational. Preeclampsia, there is an associated incidence and an increase, and for that we will be monitoring their blood pressure and urinary protein at each visit. The women will have a discussion about induction of labor and the pros and cons for this. Women with well-controlled gestational diabetes will usually make it to their due date, and those that have a baby that's LGA or poor control, we'd have to tailor advice based on that and what the woman would like to do. Gestational weight gain, there was a lot about this in the conference on the weekend, that is a predictor of many of the outcomes. And that we do have the weight cards, and this can be monitored. Practically, I think this is quite a difficult area. Women already have enough stresses, and we can't take those away, and we don't want to add to them. Simple messages like, you needn't eat for two. Sugary drinks are sort of best avoided, and treat foods are treat foods. Very simple messages that might help with this. And there's always the importance of using language, the right language, being respectful of their choices. And many of the women that come to clinics who have pre-existing diabetes have a great amount of lived experience in what they want to do and how they'd like to continue. And of course, we want to focus on the entire family and what we can do for all of them. So I've just put the targets here. Again, this is a slide because I just thought it was really good. We're aiming for a fasting of 5. And again, there is some difference in management. Some areas will choose 5.5 or 5.1 or 5.3. And then 1 hour values are 7.5, 2 hour values of 6.7. Again, some areas will choose 6.5. With pre-existing diabetes, the preconception and pregnancy values are here. Insulin use, I mean, all of you are clinicians who are well versed in insulin, so I won't go too much into it, but essentially in pregnancy, we aim to use long-acting insulin, but something like Protofen, which works over 12 hours at night, and aim to use short-acting insulin, such as Nova Rapid, with meals and boluses, because that seems to provide better management and cover through the entire day. We tend to use less of Lantus unless the women are already on it and have been on a long time and are comfortable with just that. This is just a pretty picture, sorry, of the various types of insulin. Again, I'm just giving a pictorial view of how the insulins work. So coming to what are the other risks in pregnancy, I'll just jump to the next slide. So here is from an Australian population. Unfortunately, I didn't have data from counties, but the data that we do have matches this a fair bit, and I think this is a fair representation. So in women with pre-existing diabetes, there is a higher rate definitely of cesarean sections. In counties Manukau, it's been more like 55%. And with gestational diabetes, 45%. Again, here we see it about 35 to 40%. Definitely preeclampsia is, there are increased rates in both pre-existing and gestational diabetes. Preterm birth, we were surprised when we looked at our county's data that we had a rate of about 30%, but it appears that this is sort of seen universally. Shoulder dystocia and stillbirth are both, I mean, stillbirth being the worst outcome, but it is something we all strive to aim to try and prevent. This is just another pictorial view about the complications for mum and for baby. With the baby, these babies will come to you as your future patients, or and there is the risk of being born premature, either iatrogenic or spontaneous from polyhydramnios and complications. Sometimes, unfortunately, asphyxia, especially if it's been a difficult shoulder dystocia, respiratory distress due to transient tachypnea of newborn associated with prematurity, polycythemia, jaundice, lower iron scores, and of course the long-term outcomes of cardiometabolic syndromes. I've just put these slides here for language and diabetes, and there's some really good work being done both here and abroad, and we hope that this work continues where we will continue to use respectful language. Just a few slides on that. So postnatal management, again, the women are usually, so in hospital with women with pre-existing diabetes, we will get them to start testing their blood sugars again. And here again, there are slight differences. The numbers are either 8 or 9, but if their blood sugars are at those levels, they will stop their medication or cut back on medication. Most times for women with pre-existing diabetes, they have a plan that's already put in place for them. If they have gestational diabetes, usually the medication is stopped. They monitor for 48 hours. If their blood sugars remain largely normal, then they will not be going on to medication. We would recommend an HbA1c at 3 months for them, and then yearly, and preconception. Sorry. With pre-existing diabetes, as I've said, some form of medication will, they usually will be on insulin or metformin, smaller doses when they leave. When they see you at 6 weeks and onwards, then you will manage them as you have before. Breastfeeding cannot be stressed. I can't stress on it more than anything else. We know that breastfeeding reduces rates of ongoing diabetes in both the mum and the child. The mother has benefits of a reduction in 50% at 10 years, and the infants have a reduction in obesity and type 2 diabetes in the future. Again, just some really interesting slides from Dr. Tina Clausen from Copenhagen. They have been able to have some amazing longitudinal studies on women who have had hypoglycemia and diabetes in pregnancy, and there is a great amount of evidence that it's the genetics, but also the epigenetics, sorry, that's what it's meant to say, where the intrauterine environment and the hypoglycemia of pregnancy has a large effect on what happens in future. They've seen an almost 2 to 4 fold increase in metabolic syndrome and BMI in children born to women with gestational diabetes or pre-existing diabetes. And interestingly, even in type 1 offspring, where we know that there isn't a genetic component, but just the hyperglycemia seems to increase the rates of prediabetes twofold, and there is evidence of increasing insulin resistance. I found this really fascinating. They've done some studies where there are pathophysiological changes in blood flow to the hypothalamus. So they're not only physiological changes, but sometimes even anatomical changes, where the hypothalamic area is where our response to food cues are. And these actually might be altered and make it really difficult for this person to in future manage appetite. Of course, this needs more research. The really good thing about this was that they have looked and seen that treatment of gestational diabetes or the hyperglycemia seems to help, and it's not all gloom and doom. But if women are able to, and we are all able to sort of manage that hyperglycemia, then the outcomes are not as seen. So I'd like to end by saying that yes, diabetes in pregnancy, diabetes as general, requires requires public health to be involved. It's not about just that person, but we kind of work with the person to do the best they can. And it is a whole person, a life course approach where, and this is for us in clinic when we see women with diabetes in pregnancy, that it's not about just them at that time, but it is about their entire life course and that the fetus that goes on to become a whole person. And of course, that it's all about their sleep, safety, as well as food. Thank you so much.
Wonderful. Thank you so much, Heena, for that presentation. Quite a few questions already around medication, but I just wanted to start, I suppose, just by talking about lifestyle management as well, so that we are kind of thinking more holistically. What is your approach when you're seeing your patients around lifestyle management, if they've got, either pre-diagnosed diabetes or they develop diabetes during pregnancy?
It is tailored to what's happening for them. So I think the key is to ask questions more than speak and give them advice, because that's the most important thing, knowing where they're coming from. A mum who is sort of picking up the children, then going to work, returning late at night, it's very different for her. She's not going to be someone who's being able to get to sort of exercise, but for her, it's going to be more about managing her food and her stress. In general, you do want to ask people to move more. We know in the textbooks it's 30 minutes of moderate exercise at least 3 times a day. In terms of food, again, there are very prescriptive diets around carbohydrate intake, and how you could kind of eat various types of diets. We know that a varied diet is the sort of best way to go. So it really does depend on the person in front of you.
If we move on to the questions around medication, I'll start around insulin. So could you clarify the preference for more shorter acting insulin, such as Protophane, over Lantus and the longer acting ones? Just the reasoning behind that? Had a couple of questions around it.
So with the pregnancy and insulin resistance, as well as the pregnancy hormones from the placenta, There is a lot of variation that goes on with levels of with blood glucose levels. There are peaks postprandially, which peak in about an hour and then sort of settling down to baseline. And we find that if we use long-acting insulin, it is harder to get those peaks down because I think compared to diabetes outside of pregnancy, we're looking at much tighter control in terms of an overall all day sort of control. And so we find if you use Prodafen at night, which will give you a 12-hour cover, it fits very well with testing first thing in the morning. And most women are able to get up first thing in the morning and test their fasting. We will often even teach them self-titration with that Prodafen. So that seems to cover the night really well. During the daytime, again, using NovaRapid for their meal seems to work quite well because they're able to test 2 hours after the meal and then titrate to what they need. So it's just to be able to get better control over the whole day.
Also, just a question around folic acid and just confirming when you would give the high dose 5 milligrams versus 800 milligrams.
That's interesting. There was one big talk on this at the conference. There is some concern coming through about higher doses of folic acid. But at this stage with our guidelines, we'll stick with your 800 micrograms with gestational diabetes. But when you've got type 2 diabetes or pre-existing diabetes, then we'd use the 5 milligrams.
Also, even if a woman is diagnosed later on,
Yeah.
you wouldn't increase it up to 5. You would keep them on the 800.
Yeah, we'd keep them on the 800.
Metformin dosing. So I think your slide said 2.5 grams per day. Some of us get teaching that we don't really bother going beyond 2 grams per day, I guess, in our general population because we might not get much benefit.
So again, this is just traditional. I don't know what the entire science behind it is, but we usually start with 500 milligram tablets because those are the ones we have. We'll start them with lunch and dinner because of this, the gastric side effects, and usually up titrate up to 2 tablets with 2 meals and 1 tablet with 1. So we kind of go up to 5 tablets. And most women are able to tolerate those doses without severe gastric effects. Some women aren't, and then we just have to stop where they can.
Cool. Fair enough.
It seems to help better with a lot of our women who have a lot of insulin resistance and weight gain. So it seems to be a good balance when used with insulin.
Also a question around timing of aspirin. Is it quite a narrow time that you would administer it? Is there any risk, for example, starting it earlier than 12 weeks?
The aspirin is related to placental invasion and how the placenta forms. So the best time is when the placenta is sort of invading into the uterine wall and decidua. And that's when it seems to work really well. There have been some studies about concern in the first trimester, so we do tend to avoid it. But it has been given earlier as well. So we like to say that the best time is probably once you're past that first trimester, but then beyond 20 weeks, you're not getting as much of placental growth. And so we may not get the same benefits. And the number needed to treat for aspirin is 1 in 19. So it only works in about 20% of the population. So giving it later, probably not as effective. The other thing about aspirin is there are studies that show it works better when given at night. Who knows why? So 1 tablet at night seems to be the way to go.
A question just following up around GTT testing, early GTT testing. So is it only for someone who's got previously diagnosed diabetes, or would you also give it for someone who's got a high HbA1c and on their booking bloods or early pregnancy?
So I think booking bloods, we do them if they're 48 or 50, then they're straight into the clinic.
Mm-hmm.
If you've got an HbA1c of 41 to 48 or 50, then follow your guideline for your particular DHB at this time. And once you're getting to, if you've got a HbA1c less than 41, then you'd wait till you get to 24 to 28 weeks and do a GTT at the time. So that's our current process.
Also have a question here. What would be the best approach for a mum with previous GDM, second time pregnant after 7 years? HbA1c has been 38 to 39 after first baby. However, recent 2-hour postprandial blood sugars have been sometimes in 9.5 at 6 weeks of pregnancy. Does she need to be tested early and started on treatment early?
Not with our current guidelines. We would definitely say, yes, this person would benefit from your dietary and lifestyle advice, and that would be really great. This would be a person that you would test early at 24 weeks and get them, and then when if the GTT is positive, which you think it will be, they'd then be started on treatment.
I think there was just another follow-up question around folic acid. They were asking, while stopping folic acid 5 milligrams at 12 weeks, will you continue 0.8 milligrams for the rest of pregnancy? But I'm not aware that you would ever reduce it back down. If you've started 5 milligrams, you would continue on.
Folic acid, usually we want to give it for the first 12 weeks because the neurodevelopmental process is then almost done. So folic acid is your first trimester medication. Usually once people run out of it, you won't prescribe it again.
Sure,
After
yeah.
the
So you won't worry about any more after that.
No.
Yeah. Any ideas? Quite a lot of medication questions. Any ideas on vitamin D dosing? 0.125 milligrams a month versus daily dosing?
Monthly dosing is what we're tending to use.
And as you were saying, you're kind of working on with the new guidelines in terms of having the cutoff for HbA1c as lower. Is that something you're thinking was only appropriate for pregnancy, or should we be thinking about changing that for general diagnosis management for our general population? Because obviously, as you said, in quite a lot of other countries, it is 48, isn't it?
I won't speak for diabetes. I'm an obstetrician, so I'm not sure where that's got to. We do know that some countries use 48, we use 50, but I'm not sure how you would sort of work with referral pathways. I think at the moment referral pathways still are 50. So that's where we are with that. And the national guideline, as it's still being drafted and there's been some feedback. So we're a while away from it being sort of all being rolled out at the moment.
Thank you so much. I think that's all of our questions answered at the moment. With that, I'll pass on to Dr. Sue Tutty for her regular update.
So I'm going to start talking about the musculoskeletal national pathway and then a discussion on MPOC, some of the PRIMAC updates, including some follow-up from last time, and then a section that I've called Looking Forward, just to start a discussion point on some of the things that might be relevant to primary care. So firstly, the national musculoskeletal pathway. So this is a hospital-based pathway that has been put out for deployment from August. So it should be happening sometime in your area, sometime soon. It's based on referrals to the orthopedics service. And what we're asking primary care to do is to advise patients that when they are referred to orthopedics, they may be given that assessment by either an orthopedic specialist or a physiotherapist. And these physiotherapists will have completed an advanced training before they are put in this position to take the referrals. This is part of the work that's been done by the Planned Care Task Force to try and ensure that patients get the right pathway of care sooner. And it's also to support the waiting lists and waiting times for orthopedic FSAs. Now, don't confuse this with the ACC Integrated Care Musculoskeletal Pathways and some of the other works that's happening in other districts. But this is a national pathway that will be implemented in the near future, if not already in your area. A quick update on MPOCs. So ESR has updated their risk assessment for MPOCs, but it's still low or low moderate. But there is some concern starting with this particular variant, the Clade 1 MPOCs, which is of some concern because it's behaving differently to the Democratic Republic of Congo. And they're seeing people that are younger, under the age of 15, equal numbers of men and women, and with transmission both sexually and non-sexually, which is quite different from the Clade 2 variant of Mpox, which continues to affect mostly gay, bisexual, and other men who have sex with men. So just letting you know that there is a national health pathway for Mpox, which we have noticed that a number of people are accessing, and that it will provide information for you on identification of cases and on vaccinations. So the Pathways team are working closely with public health to ensure that their pathway remains up to date. And also there is a new travel advisory out for people travelling to Mpox affected countries, and there's a link there that will be in the slides. So moving on to the Pharmac updates. Cilazapril we keep talking about, but apparently there's still 14,000 people still on Cilazapril. I've included my slide that I put in last time, which just shows that these expiry dates are coming up very soon. So October and November, we expect the stock to run out. And just for your references, the equivalent doses are there. Estradiol gel we talked about last month, and the consultation proposal is now closed, and there should be a replacement product in place by the 1st of November. So that's really good news. I wanted to talk about copper IUCDs. This is something that there hasn't been a lot of discussion about, but just so that people know that there are supply issues. In fact, the TT380, which has been the most common device that we've been using for copper IUDs, is going off the market, and Pharmac have sourced a different, slightly different IUD called the T Copper 380 Plus Normal. It's of the same dimensions as the old choice TT380, so it's still got that quite wide 29.9 millimeter width to insert. The Choice Load 375, which it was always a lovely choice because it's got 19.6 millimeters width. It's a great one to use, particularly for the post-coital contraception, is also not available. The stock ran out in May 2024, and there isn't an alternative available at the moment for this one. And the Choice TT380 Short has been replaced by the Nesha Silver Copper Short, and it has the same dimensions as the old one. But just a few points to make about the new replacement for the TT380, particularly that the length of action is only for 5 years. So that 10-year action that we had with our Choice TT380s is gone, which is a real shame, really. And to note that there's no copper on the arms of this new device. So please, before you're putting in a different device, make sure that you check the instructions very carefully and know exactly how to insert it. It looks actually very similar to what the Choice TT380 was, but just make sure you familiarise yourself with that. And those dates to remember, the new one will be coming available from the 1st of September. The remaining stock of Choice TT380s will expire at the end of September, and the product will be delisted at the beginning of October. Methylphenidate extended release. This is a global shortage of this product. So from the end of August, there may be, right until probably the middle of next year, there's expected to be gaps in supply of both Concerta and the Teva brands. So the advice is that if you've got a patient new to treatment, don't start them on the extended release products because they may have trouble sourcing it, and look at the immediate release or the 8-hour formulations. If you've got someone who is currently on the extended release preparation, this will need a individual case-by-case decision. It may be that their medication does remain available, and it's a matter of checking with the pharmacy to make sure if there's supply or not for their particular strength. It may be that a treatment break is an option. And if you are changing to alternative forms, is this going to be a permanent change or just an interim one? And finally, does the patient have the appropriate special authority? So my next slide shows that a little bit more clearly, that there are two special authorities, if you see at the bottom of that page, and one covers concerto and Ritalin long-acting, and the other one covers the other products. So you have to make sure that the special authority that your patient has will allow them to access the new combination that you might have sourced for them. So I've just put in the different products that are available of methylphenidate on the market and the strengths that they come in. So the advice is that you can calculate an equivalent daily dose, so it's dose for dose, basically. But you've got to think about the release profile of the preparation, so how quickly it gets released into the bloodstream, and the time period that it will cover. So in fact, if you're wanting to give a 12-hour dose over 8 hours, it's going to have a different effect, obviously. And the suggestion is that perhaps that 12-hour dose could be achieved with an 8-hour formulation, followed by an immediate release formulation later in the day. And the immediate release ones usually last about that 4-hour time period. So there's a graph here, and you can see the pharmacokinetics of it. So the Ritalin long-acting that has a 50-50 release of 2 times has the 2 peaks, in the same way that the methylphenidate immediate release one, which is 2 doses of the grey on the graph. So it's with a bit of thought, you're able to work out what would work for your particular patient, and then have a discussion and see how it goes, really. So finally, looking forward, I just wanted to present some topics that in this section that are being talked about in primary care that are not necessarily happening at the moment, but that we need to start thinking about. And tonight I've chosen advanced care plans and advanced directives. So in an advanced directive is consent or refusal to us for a specific treatment that may or not be offered in the future when a person no longer has capacity. So to be a valid advanced directive is legally binding, but to be valid, it must have been created by a person who has capacity to do it, who was appropriately informed and undertook the process voluntarily. And the directive only comes into play when the person has lost capacity, and it must relate to the current situation. An advanced care plan is a process of thinking and talking about your values and goals and what your preferences are for current and future health care. It may be written down, and it may contain an advanced directive within it. So then I wanted to talk about severity assessment codes, SAC codes, which is a process of recognising and reviewing and reporting harm. And there's 3 levels of SAC codes. So there's a SAC 1, which is severe, death or harm causing severe loss of function or requiring life-saving intervention. SAC 2s, which are major harm causing major loss of function, and a SAC 3, which is moderate harm causing short-term loss of function. And all these examples are not related to the natural course of the illness or treatment and differ from the immediate expected outcome of care. And the harm can be physical, psychological, cultural, or spiritual. So what's happened is that had looks at these serious events and HDC cases, and they have provided some guidance. This is only guidance. It's not expected to be prescriptive, but it is expected to start some conversations and start thinking about how we view advanced care plans and advanced directives. And this advice applies to primary care, but it also applies to hospital and specialist services, hospice, ARC. This is across health services. But a missed advanced directive is considered a SAC1 event. So that's your most serious event. And they've given, as an example, an advanced directive that is not accessed or not followed, and that leads to the delivery of the treatment the person stated that they did not want. And a missed advanced care plan has been considered a SAC2 event. So an advanced care plan, or whānau plan, or shared goals of care that is not recognised, unable to be accessed, or not followed, leading to unwanted significant interventions. So what does that mean for us in primary care? I think it's well recognised that there are a number of IT problems to the way we can identify advanced care plans. But it's just a chance to start thinking about these, thinking about the discussions that we're having with our patients and how we could make these plans more visible in our practices. If a person has an advanced care plan, do we know that they have them? And how do we, if we've developed an advanced care plan, how do we make this visible across the health system? So while the SAC1 and SAC2 events are just a guide for guidance at this point, and there's a fair bit of discussion that needs to go into this topic, it's also one that we need to start thinking about, and thinking about what weight we give to the choices that our patients want to make. Thank you. Any questions?
Thank you for that, Sue. So we've had a couple of questions come through already. First question was just following up on mpox. Any updates on the vaccine program?
I think that there are updates. I think probably the best place to go for those are pathways. There is a plan, I think, to make the vaccines more available, particularly to our at-risk populations.
And this is a question you may or may not know. Given that the spread might be different between the different types, will the at-risk populations therefore be different compared to, say, back at the start of last year, when it was mainly men have sex with men who were being offered the vaccine last time around?
Absolutely, there is that possibility, and I think our public health service are onto this and are thinking about what strategies we will need to put into place if it is becoming a problem in a different population than what we have traditionally thought of with mpox. I know that that's certainly under consideration and plans are underway. So I think we just have to keep looking at the pathway, seeing things as they update.
Just to follow up regarding methylphenidate, just some questions around special authorities, and basically if there is a need for a new special authority because the brands that someone already has under that special authority isn't valid, what is the way of going that? Are you aware of any opportunities that GPs would be able to apply given it's a shortage issue, or does it still necessitate a psychiatrist referral and or at least psychiatrist advice for applying for a new special authority if we need to be switching formulations in order to make up, for example, you were saying in the absence of long acting, use a intermediate and a short acting?
My understanding is that there are no plans to update the special authorities, and the advice was to make sure that it works within that special authority. I do appreciate that that might be tricky within one of those categories, and could certainly go back to Pharmac and ask them.
Mm-hmm. Sure, but as it stands, we probably would be needing to still refer back to psychiatry if we're needing special authority, or at least perhaps getting referral for advice, online advice, if it's not necessarily another full consultation, perhaps if they're willing to give online advice based on GP, the question the GP's raising.
Absolutely, and it is just written advice that's required for the special authority.
Okay, those are all the questions we actually have at the moment. So I think we will bring it to a close. So I just want to finish by thanking again our two speakers for tonight. Heena and Sue, thank you for all your contributions tonight, and also thank you for all the participants who sent through questions. Hopefully we answered them to the best of our abilities, and we look forward to seeing you at our next event. Thank you so much for your time.
Thank you.